By the 1970s, psychiatry's sepia-tinged confidence was starting to waver amid deinstitutionalization and heated debates over diagnosis. In 1973, psychologist David L. Rosenhan published On Being Sane in Insane Places, asking a stark question: can clinicians reliably tell sanity from insanity? To test this, in 1972 and 1973, Rosenhan sent 8 pseudo-patients, 3 psychologists, a psychiatrist, a pediatrician, a painter, a housewife, and a psychology graduate student, to 12 psychiatric hospitals across the United States. Each reported a single fabricated symptom, hearing voices that said empty, hollow, or thud. Their goal was to be admitted and then observe how they were labeled and treated, a study with major implications for trust in medical authority and for patients' rights. They arrived between late 1972 and early 1973 at 12 psychiatric hospitals across 5 states and the District of Columbia. One of them was David L. Rosenhan. In total, there were 8 imposters. Each presented the same single complaint. They were hearing a voice that repeated the words empty, hollow, or thud. Intake clinicians, after brief interviews and cursory histories, almost uniformly recommended admission. Diagnostic slips and chart entries quickly labeled them schizophrenia or similar psychotic disorders. Subscribe. Maybe clicking it would have saved their sanity. Hospital psychiatrists and staff then interpreted mundane gestures and lucid conversation through that diagnostic lens. Institutional procedures took over immediately. Identification bracelets, ward placements, prescribed psychotropic medication, and staff notes that reframed normal behavior, taking notes, reading a newspaper, asking about meals, as symptoms. The real shock was not just how easily and consistently they were diagnosed, but how ordinary behavior was overwhelmed by clinical labels, pushing the pseudo-patients into the experiment's next desperate challenge, proving they were sane. Inside the wards, life settled into a brass-laden routine. Morning head counts, rigid medication rounds, and narrow meals pushed from steel carts. Nurses handed out antipsychotic medication on strict schedules. Psychiatrists stopped by for brief 5 to 10-minute visits, leaving day-to-day control to the ward staff. Chart entries turned ordinary acts into pathology. Note-taking became quote-writing behavior, quote. A smile was labeled, quote, inappropriate, quote, and a simple request for soap read as, quote, dependent, quote. Staff conversations and casual observations were compressed into diagnostic shorthand that only reinforced the initial label. The pseudo-patients, including Rosenhan, kept meticulous, ink-stained field notes, covertly recording timestamps, verbatim exchanges, and the growing gap between written charts and lived reality. The moral toll sharpened, mounting frustration, humiliation, and a quiet resolve to expose how the system misread them. They counted and documented every discrepancy. When the pseudo-patients were sent back into everyday life, they behaved lucidly, kept records, repeatedly asked to be discharged, and insisted they were well. Yet hospitals held them for days or weeks. Admissions ranged from 7 to 52 days, mean 19 days, until staff signed off with notes like schizophrenia in remission or diagnosis schizophrenia, showing how labels stuck long after observable behavior changed. Release often required staff-initiated discharge rather than any clinical vindication, turning freedom into a bureaucratic decree. Rosenhan recorded each denial and every perfunctory psychiatric interview as evidence of institutional inertia. After the paper appeared in Science on January 19, 1973, one challenged hospital reported that, when warned to expect imposters, it flagged 41 of 193 new patients as suspected fakes, though Rosenhan had sent none. That defensive detection exposed diagnostic unreliability and shocked the psychiatric establishment. On January 19, 1973, Science published David Rosenhan's paper, and within days, the sepia veneer of psychiatric authority cracked under a blaring media storm across newspapers, television, and professional journals. The empirical blow was stark. 8 pseudo-patients were admitted, they endured long hospitalizations, and a follow-up episode in which a hospital that had been warned identified 41 of 193 new patients as suspected fakes, even though Rosenhan had sent none, amplified the scandal. The results ignited furious debate at the American Psychiatric Association and in academic circles. Hospitals issued defensive rebuttals and promised procedural changes, but public confidence faltered as clinicians' judgments proved fallible and diagnostic labels proved stubborn. That collision of clear data and institutional defensiveness dealt a decisive blow to diagnostic authority, forced psychiatry into harsh scrutiny, and fueled demands for concrete reform that helped push the field toward operationalized criteria and the eventual overhaul in DSM-3. In the aftermath, Rosenhan'S experiment triggered sustained scrutiny of diagnostic practices and institutional care. It accelerated demands for clearer operational criteria and greater diagnostic reliability, helping pave the way for reforms that culminated in DSM-3 and contributing to shifts in deinstitutionalization and patient rights activism. At the same time, the study raised serious ethical questions about deception in research and left a stark lesson. Diagnostic labels carry a sepia-stained power, and the field needs robust safeguards, transparency, and humility.